All right.
Barb Opperwall, nurse practitioner, has been doing palliative care in the West Michigan region for, I'll just say quite some time.
Quite some time.
I met Barb
Thank you.
first when I was a fellow as well. So worked with her in a few different capacities along the way, and she is the expert when it comes to family meetings. So we're happy to have her here today and talk to us more about that.
Well, I'm really honored by your introduction, and I hope that all that's true. And let's get started. Our topic today is about effective family conferences. Sometimes this conversation could be called difficult conversations, how to have a difficult conversation. You can see by my credentials, I'm now retired, and one of my credentials is in retired but active state. And I could not maintain the clinical hours. I do have a very robust pro bono friends and family home consultation service that remains. It's been kind of astounding that people have recognized I have a little bit more time and they have a little more time for me. I have no financial disclosures, and you can see where I spend my money. And this is some of the travels for this year. And we have some objectives today. So we're going to talk about how to prepare for a family conference, which is a step often missed, how to conduct an effective conference, the kinds of variables that influence the conference itself and the outcomes, how to present really difficult topics, and how to know who you are and what you're bringing to the table. So first of all, what is it that we're talking about? So I'm going straight to the research because there could be some questions about this. So throughout the conversation, I've tried to highlight some of the known board content that we have. And sometimes they'll kind of hit you with what looks like a softball question, but can be a little tricky. But anyway, it's obvious. It's a meeting between the patient, their family, and the healthcare professionals. There are a lot of reasons. We share information or concerns. We're talking about goals of care. We're talking about the actual medical condition from diagnosis to prognosis. We're developing a plan of care for the patient and for the family. And believe it or not, it takes some skill to do this well. So most people can talk to people, at least sort of. But think about this. Do we as palliative care experts get the easy family meetings, where it's an advanced age or an expected decline, or do we get the hard ones? We know we get the hard ones. They're really unanticipated kind of catastrophic illness, or the patients are super young, or they're estranged family members. We get the really tough ones, and we often get the ones where someone previous to us has gone in and made some attempts. And so you have to recognize going in that we don't always get to start with a fresh situation. There may be some things that to say we have to undo them would be unkind, but that we have to recognize that there may have been some conversations already that we have to maybe uncover and recognize is just putting it gently. And so we know as palliative professionals, we approach any professional situation by preparing, by having practice in the situation, by developing experience, and by having a plan for it. I promise you, people who do this well are not just winging it. It's no different than if you have a lot of experience in palliative care. I can do opiate conversions in my head. I can do that math in my head. I can also make change, which apparently is a really big skill now in modern checkout sales. But
change like
passion.
I thought you meant change meds. I was like,
it's no different. With experience, you can do those opiate conversion calculations in your head, but you're still doing the calculations. And we all learn the hard way usually that if we're taking someone new through opiate conversions, we have to make them do it on paper. Because if they try to do it on their head, they're often going to make errors. And the same thing happens in conversations like this. First, you have to start with doing all the details, and until that is such a solid pathway neurologically that you can just do it in your head, people don't have to see it. Now, I'm bringing the Dunning-Kruger effect slide in, and this is a new one for me, and this is familiar to you all. This is a study that came out in 1999 and has been replicated multiple times in multiple fields. And essentially, it says that it compares confidence with expertise. And typically, and what they found, and they did just pen and paper tests, grammar, math, and some humor. And the people who had who started this, typically people had a high confidence in their ability to perform, and they had a very low quality or expertise level. And this was stunning. And this is no different if we use some common sense. We see this, for example, in teenagers tipping into adulthood who have an incredible amount of confidence in their ability to manage adulthood and tend to act at the height of stupidity at times. And it takes some time. And I'm going to say that if you develop some experience, you tend to move really deeply down the valley of despair. And I think one of the fellows mentioned to me that that's probably where they are in terms of this topic. And I just respect that deeply because that's finally when you can learn, when you recognize where you are. And if you're not asking questions about your capacity to do a family meeting well, if all of us are not asking that question, then we are probably on the early side of the curve instead of on the expertise side of the curve. The unskilled typically in this effect, we suspect lack the knowledge to recognize their own errors. And I'm putting this out partly because in the last couple of palliative lectures on this topic, we talked about whether I'm presenting an ideal condition or whether I am presenting our standard of practice. And so that'll be a question that I want you to contemplate as we go through this. Am I presenting something that you hope you achieve, or am I presenting our basic standard of practice? So what skills do you need for a family meeting? You have to know all the medical stuff. And I'm always surprised that many specialists tend to think that palliative care providers have a very soft amount of medical knowledge when we really have to have practical knowledge at specialty level across multiple specialties. And so you have to have some comfort with that or know where you're going to get good information. You have to be able to facilitate a group. Empathy is really important. Patience really helps. Having counseling skills are good. Conflict management skills, and these are different than counseling skills. And you have to be willing to provide guidance in decision making, which means you have to be able to process information deeply. And so there are a lot of skills to have, and you'll notice that they don't really overlap. There are a lot of different skills to have, and they don't necessarily have a good overlap with what you already know and what you're doing every day. So why do we have family conferences anyway? So first of all, we often are giving information. We want to clarify if there is confusion about information or if there's a communication challenge. We want to develop or define a plan of care. We want to get everybody on the same page. And trust and support for both patient, family, and usually our provider team is really important. So again, is this ideal or is it evidence-based practice? So think back. Were you ever taught to have a difficult conversation? If you're having these difficult conversations, where did you learn the skill set? Are you basing your difficult conversation skills on what you learned as a child at home and how conflict was managed in your home? Are you basing it on how you manage conflict in the school setting? Are you basing it on how you manage conflict in your relationships? Or are you basing it on something that you actually learned in terms of a skill set? I challenge you to think about that because a lot of us are really initially basing our difficult conversations on what we learned approximately in kindergarten. And so if that's your skill set, that's also probably going to be your outcome level. Who is going to have natural skill at it? Of course, some people have natural skills, but we don't really know who those are. Be careful about assuming that you are a person that comes with natural skills. But there will be people who have some natural skill at it for whom it will be easier. I, by nature, sit exactly on the introvert-extrovert line, and I present in situations like this as an extrovert, but it's a learned behavior. And so I will be taking a very nice, soft afternoon today, right? Actually, I'm taking a class that's on the Beatles. I think it starts today. I'm really excited about it. So in what situations can our best practice about difficult family meetings be deferred? When do we get to say, I'm going to skip some of the steps to do a family meeting well? Are there situations, do we skip best practice when we're trying to do pain management? Do we skip best practice when we're trying to do nausea management or manage constipation? I think we tend to prefer best practice in all the things we do. So I'm challenging you to be really careful when you choose to have not best practice in a difficult conversation to save time, or because you're stressed, or because the environment is not great. Be really careful if you're choosing it. And I will say, particularly in critical settings, and I spent most of my life either in critical care or having regular contact in critical care, so I'm not unfamiliar with critical life settings in healthcare. those settings can be really difficult to do a good family meeting in. And they're really high pressure, high charge. Do we have by habit in that setting some things that we keep best practice at and some things we let slide? Those are just challenges. So I will alert you also that patient and family tolerance of a less than ideal family meeting certainly will be based in part, at least, on gender, age, race, and the credentials of the professional. So what I'm going to say is that older white men who are physicians are going to have a much higher tolerance from patients and families with very poor types of family meeting setups. Let's be real here. Whereas my brown-skinned, young, female NPs and PAs are going to have a lot less tolerance from families if it's not an ideal family setting. And obviously, I'm not old, but I'm a white nurse practitioner. And so I really have had by this issue to be pretty precise about family meetings so that I don't have families just lost at the first impression by bad practice. So is there any evidence? Yes. So at this point in our work or in the fellowship practice, the original research on meetings like this and even family meetings is in business around sales. It's in sociology and psychology, it's in anthropology, and it's in education. So the corner on the quality research in this area is not in healthcare. And if you're not reading outside of controlled studies in healthcare, you're not going to have seen this literature. That doesn't mean the literature is not there and that it's not good literature. We know, though, that well-established research on family meetings are present, including how to do this for ICU patients, oncology patients, the OR, and many more. And most of you who've heard me before know that my research way back in the day, which is a really long time ago, before all except perhaps two of you were born, is on family meetings, because back in that day, family meetings, even family visits, were 10 minutes every 4 hours, 4 times in a day. That's how much time. So 40 minutes a family could have with a family member in the ICU, with a patient in the ICU, and it could only be 2 people at a time. So if you had a big family or had multiple kids, not everybody could even get in once on a day. And now you see those open visiting hours that are in critical care and those open family meetings around that time. So I had just teeny tiny part to do with that. So it is very hard to do double-blind studies on human interaction, mostly impossible. And a lot of the research is phenomenological. And because we are looking at controlled double-blind studies to get really valuable input, tend to toss phenomenological research out. But phenomenological research, which is the study of an individual's experience, the listening to their story, the detailing of their story, in some of the other disciplines, and Brene Brown being, for example, a sociology expert, has said maybe stories are really data with a soul. And we really are facing souls. And so it's something for us to think about. I've been asked, can being empathetic be learned? Can you learn empathic communication skills? The answer is yes. Please know, though, that empathy works so much better if you're not just acting. Nobody cares how much you know unless they know that you care. And believe it or not, less than a minute, 30 to 40 seconds of some kind of emotional support and human interaction can completely transition how a patient and family experience you and really dramatically reduce anxiety variables in patients, which is really a good thing. Now, I'm not saying you have to chat them all up, although I really don't mind if you do. But I want to tell you that families and patients who experience you as remembering key critical human things about them experience your difficult conversations ever so much better. And simple questions like, either to the patient or to the family, what are the things you like most to do? In the last 6 months, what's the one thing that you haven't been able to do anymore that you really miss? Understanding those things. Who are your favorite people? And I recommend highly that you note these down. I do not have a specifically excellent memory. My late great colleague, Dr. Mulder, had a nearly photographic memory. And so that was always kind of a challenge to me because he could remember everything that anyone told him over long periods of time. For me, I needed to note it. But across time, we experienced that if you have noted in your planned care that this person really likes to fish and is looking forward to this, or has a boat, or Mrs. Little things, whatever it might be, their pet. Your colleagues who pick up from you, unless you are sure you're going to be the only person who's going to be with us, your colleagues can also pick that up. It's really hugely vital information to have in the record. And it's really an excellent opportunity that's often missed. So is being empathetic, is empathy just a feeling we have, or is it a choice? And there's a lot of conversation about it, and I'm going to just talk both sides of it because I believe it's both. But it's a vulnerable choice, because to connect with people, you have to connect it with something in yourself that recognizes that feeling. And empathy is being with a person, not just for them. So this is not automatic. It is a conscious choice to connect with them, even on an emotional level. And I think probably all of us have been told, don't connect emotionally with your patients. I think that's bull roar. How can you not, in the kinds of conversations we're having? And so making that human connection and responding in a way that acknowledges their experience is going to really help you out in the situation. It's part of your preparation. You need not only cognitive, but also emotional, behavioral, and a moral capacity to respond to the suffering of others. And in the situations we're in, suffering is what is present. So you got a lot of stakeholders. Your patient is the stakeholder. We think of them automatically in the family, but the referring providers are huge stakeholders. If you tick off your referring providers, guess what? Your business tanks. And a lot of us don't like to think of what we do in a business model, but we have got to maintain a high caliber of practice that makes everybody want the product that we provide. And if you're not paying attention to that, you're going to eventually run into a lot of trouble about it. And I'm here to tell you that the caregivers at the bedside or in the home and the staff are also huge stakeholders for you. And if you're ignoring them or not being kind to them, they can really sabotage your work. Listen, I have been that nurse in the ICU who medical students knew not to cross, right? Don't be telling me you'll ask for my opinion if you want it. Child, you're going to die today. So where do we do all this family conference stuff? We do it anywhere the patient is. So it might be in the hospital. That's very common. We have a lot of us working in direct referrals for meetings in hospitals or in a hospice facility, in any kind of senior living kind of facility of any level. We do it at patients' homes. We do it in our clinics, and we do it anywhere we are. And sometimes we do it remotely. So they can really be anywhere. And you have to be ready for all those areas. And specifically, your role in the meeting is multifaceted. You're not only the host, but you're providing care, usually symptom management. And you have to still be a skilled group facilitator. You have to tolerate interruptions and movement around the room. You have to mediate conflict, and you have to translate a highly technical scientific language, medicine, healthcare, into whatever language the patient is speaking and the family is speaking. And so you, generally speaking, are not going to be an interpreter, but if you're not able to speak the language of the people that you're trying to have a meeting with, you need to work with an interpreter, and you need to know how to do that and do it well. And if you haven't been taught how to work with a translator, with an interpreter, I am here to tell you, you are probably not good at it. I watch people deal with interpreters either on the phone or in person, and they tend to vomit a paragraph and then wait for the interpreter to say that whole paragraph. Now, without having talked with them at all, I highly recommend, if you have an interpreter, you connect with them at the beginning of the meeting, hopefully not with the family present, but even if they are, and just explain, here's how I go about it. Here's what I'm hoping for you. And we're going to be talking about, we're going to have a difficult conversation. And if you have questions, I want you to raise your hand and stop me so that we can take time for questions. If you haven't done that, and if in your experiences with that, the interpreter is talking a lot, the patient's talking a lot, and you get 6 words back from the interpreter, you know that if the problem is you, the problem is not the interpreter, the problem is not the patient, the problem is you. And so you need to practice and learn that cadence, which is don't say more than 8 words, take a pause, so it really becomes a dance. You say da 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 da, the interpreter goes da 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 da, the patient responds, or you continue da 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 da. Keep your eyes on the patient. we probably could do a whole lecture on this. This is all I'm going to say. We're going to get some Sims that'll help with us for the fellows, but know your role and your responsibility for that. Your goals. We talked about inform, clarify, plan, get on the same page.
Today about 9 o'clock.
We're good.
Support, trust, etc. And so you are going to be developing goals for the patient, for the family, for the healthcare team, and for yourselves, for your own specialty, and for you as a staff. So let's get down to some nitty gritty. What do you know about your own decision making? So we're expecting patients and families usually to make some critical, life-changing decisions. What do you know about your own decision making in a crisis like that? Is it great? What do you know about your own decision making if you're afraid, or if you're angry, or there's a time pressure, or you feel sick, if the environment is strange and unfamiliar, if there are pre-existing stresses in your relationships among your family or among you and the staff? Be ready for meeting subtext. If there has been a bad interaction between some of the staff, whoever they might be, and the patient or family, that subtext they may not tell you. Check it out, though. It's okay to ask your colleagues going in what's happening here. Also know that you bring bias to the meeting. Now, I'm not talking exactly about implicit bias. That's really a separate topic with a separate lecture. But you need to manage the bias you bring to the meeting. So here's this real life case. So there's a tall female. She is in her 60s. She's white. She has a lot of privilege. She's clearly affluent by travel pictures. She's generally healthy. She has a stern face with a scowl and a furrowed brow when she's intense. She appears experienced. She's self-determining. She's socially supported. She expects truth-telling and gets ticked off if people tell lies. And do people ever fudge the truth with us, right? About smoking or about, flossing? Of course. So when I come in, sometimes I can be a little cynical. We all know we're talking about me, right? So I bring all this into the meeting, and I have to be aware. So back in the day when the fashion for nurse practitioners, because I was in that first wave of nurse practitioners, the cutting edge, of course, which was considered insanity in West Michigan. And so, man, I was in suits and heels and the little bow ties, And, I'm cruising in my heels at about 6'2", and I'm freaking intimidating. And that is not exactly helpful in this kind of situation. It was helpful in the business work I needed to do in breaking through some gender ceilings. But so just know what you bring and know that your appearance. So if you have had, if you're an hour 32 of your shift and you're exhausted and you haven't slept and you haven't had a shower and your lab coat is stained, just recognize that that brings some bias to the meeting and some influence to the meeting. I'm not saying that can't work. I'm saying you have to know how to manage it and manage what you bring. I'm also just going to gently slip in. You care about the stakeholders. Is this just one more patient to check off before you get to go home, or before the next 6 you have to do after that? Do you care about the people that are making referrals to you? Do you care about what they need? Do you care about the patient's family? Some people are really hard to like. They're really hard to just be with. They might smell. They might have bad language. They might be insulting. It's hard. Do you care about the staff, the caregivers? Think about that. If you don't care, they're going to know. So this is a board's kind of question. It's the statement of established best practice in palliative care, or one of the statements. And it talks about being sure that you take care of the setting of a family conference, that you address the perceptions of the family, that you invite them to share what they know, and then you ask if you can share what you know. You address their emotions empathetically, and then you strategize and summarize with a plan. We're going to have a whole lecture on who the decision maker or decision makers are in the conference. So but you need to know before you go in who actually gets to make the decisions in this meeting, and be sure you have verified it, because a lot of people make assumptions about this, and a lot of problematic choices are made by providers around this topic. Is the patient going to be the decision maker? And you're going to want to verify capacity. Of course, we're going to want their voice in, but is the patient the decision maker, or is a patient advocate or a medical power of attorney, durable power, the decision maker? And is that confirmed or is that just hearsay? Or does the patient have a guardian? And who's the decision maker in the context of that guardianship? And often patients do not carry their guardianship papers around there. So this can be a late breaking finding. And so just consider whether the situation that the patient is in psychosocially might be something in which a guardianship is present. Or is it family consensus? Because in the state of Michigan, there is no succession of decision makers. Or are the providers going to be making this decision? So we'll have that lecture another time. So setting was our first step. You're going to review the chart, of course. Sometimes you want a meeting before the meeting, either with the referring providers or with the staff. You want to figure out what's up. You want to look at the room and the place. I mean, maybe you can have a nice private room. Maybe you're going to do it at the patient's bedside. I put tissues in there for the obvious reasons. I highly recommend being seated if at all possible. And so particularly having your head level and eye level below the level of the patient and the family, if at all possible. I know it's the beta position. There's a reason for that. It pulls that intimidation, sucks that intimidation right out of the room. It can be really important. And it does kind of relax everyone, settles them down. Please know, though, until you get in there, you're never going to know what's going to happen. And please know ahead of time that if you're gunning in that meeting to have the decision made, that may not be realistic. You really may need to have two meetings. A meeting where you deliver, essentially the warning shot. We have to have a difficult conversation. This is not going the way that we had hoped. If things continue in this regard, difficult thing we'd like you to consider. We will come back at 3:00 and see what your questions are and talk about what decisions might need to be made and then come back again. So that is a very reasonable and common way. Particularly the pandemic helped us know that effective meetings need to take place, but can't always be face-to-face. And the pandemic, small, teeny tiny silver lining is that virtual meeting platforms really became completely accepted abruptly. And not only that, but reimbursable, which was a huge barrier prior to that. There are issues around telehealth consent. Be sure you understand what those are, particularly in your setting. Be sure that confidentiality is being maintained. That's usually based on your platform. These are not always just visual. They are audiovisual. They can be just audio. So telephone basis, that's still okay. Be sure that if there is audiovisual, that you understand what they're seeing behind you and understand what that impression will be and assist the patient and the family to participate. And so you have to consider things like sound and if everybody can participate in here. And you may need a few skills because if this is not your savvy, be sure ahead of time you figure out who in the meeting is going to make that platform and that process work. Because stumbling around with audiovisual technical difficulties at the beginning, I promise, does not make the meeting go better. It does not build confidence. So if it's not your jam, be sure you figure out who helps you with that. And there are going to be reasonable people. I mean, probably the youngest person present in the family is a really good resource. So there are going to be people around, staff for sure. Okay, we're going to open the meeting. I highly recommend that you take the time prior to the meeting to make sure the patient is comfortable, whether the patient's going to be present in the meeting or not. Because if the family's at the bedside and the patient is miserable and you're trying to pull them from the room and say the staff will make them comfortable, that's not really appreciated. And so take your time to go in and make sure, a half hour before, or send someone in or call the nurse, whatever you need to do and are capable of doing to make sure the patient is comfortable so that the family feels like they can be with them and talk or step away for a minute. When you choose your place in the meeting, please choose a safe location for yourself. The self-care is important. Danger is not okay for you. We're all against that, but sometimes people will walk in and go to the farthest corner of the room because there's a whole trail of people that have to go in and have themselves cornered, particularly if issues escalate and don't have a good escape path. So really scope out the space, decide where you're going to be in the meeting, and choose that wisely. I have talked about sitting down. Make sure everybody who needs to be there is present, particularly decision makers. Acknowledge everyone in the room. I recommend you say hello, that you get everyone's names, and for Pete's sake, write them down. You want to know who was there and you want to record in your documentation who was there. And if you're not a good recorder and talker simultaneously, which not everybody is, you really need to assign someone to do that for you. It needs to be not one of the family members. And so for safe decision-making, you need to be able to write down who made this decision, particularly in family consensus decision-making, which is a lot of the time in Michigan. And you need to be able to identify who is present. Tell them what you are, who you are, and what you're bringing to the meeting, why you're meeting, and start with the patient story. You say, we need to talk about some things about the patient. Tell me about your dad. What are the most important things I need to know about your dad? It's a really good opening statement to get things rolling. Sometimes they'll talk a lot, sometimes they won't, but you can learn a lot if they don't talk about their dad. You can get tensions, you can see who in the family talks, and you can learn with a simple question like that, who in the family is really in charge of the meeting. So I'm going to tell you a secret. So my mom is 91. So there's been some healthcare, obviously, in the last 5 years. And I have 3 siblings, and there are 3 outlaws besides, and there are grandchildren, and there are great-grandchildren. And if she's in the hospital, a lot of us are going to be there. And I sit in the back corner. And if the healthcare providers come in to round, they'll talk to the person who's closest to her bedside, usually one of my brothers. And they'll ask a question. What do you think happens in that room? I'm the oldest daughter and I'm the healthcare provider, right? What do you think that happens? Everybody's head turns to me, right? Even my mom. Not because I'm bossing her around or pushing her around, but because they have relied on me across time. I'm using that as an illustration to say that simple question gives you not only the answer about the patient, but it gives you a huge sense of what are the dynamics in that group. Read the room. Read the room. Because without the sign off of that person, and I start to do it on purpose because it's hugely amusing, but it's a little tricky because I have worked in pretty much every setting in this area. And so a lot of the providers or staff know me. So that's a little bit weird, but I go undisguised. So we're going to get the meeting going now, the gist of what you want to talk about. This is that invite the people present to tell you what they know about the patient's condition. They often don't exactly know what's going on, or there are some gaps, or not everybody's in the same place. And there are some simple questions. Here is a really good starter question. Tell me what the healthcare providers have told you about the patient's condition. How do you think things are going right now? How has it been going about the past 3 to 6 months? What types of changes have you noticed in your patient? Often, they're in this crisis of this sudden catastrophic event, but there have been clues over many months. And if they're stuck in, we have this abrupt event, it needs to be fixed, they can be very challenged by what you might have to talk about. But if you can bring them along by helping them to see, hey, there have been some changes over the last few months. These are really helpful questions for getting the meeting started and finding out where they're at. This step is very commonly skipped, which is risky, in my opinion. You also need to figure out how much does the patient want to know. Some of us, maybe all of us, have been in a situation where you walk in the room and they say, we only want to hear good news. We'll talk more about that. Then it's your turn. Ask them for permission. Can I bring you up to date about what's going on? I've been reviewing the chart, I've been reviewing the case, I've been talking to the patient and the providers. Can I tell you what's going on from our viewpoint? Be succinct. Don't natter on and on and on. I'm a talker. I got to be careful about that. I also wave my hands around a lot. I have to sit on them. Just know yourself and how you present. Talk about the burden of suffering and the benefit of treatment. Pros and cons typically are not as helpful as burdens and benefits. And help them understand what's being done to keep the patient comfortable. So we're really concerned about a patient who's crashed and they're on 3 pressors and they're intubated or trached and vented, and they look completely comfortable because they are completely sedated. And the family look at them and think, well, finally, they're breathing fine and they're comfortable. What's the rush? What's going on? Where we can see physiologic changes that can't be sustainable. And so you often have to let them know we've been doing such a good job to keep them comfortable, but here's what's going behind the scenes. And if you have to give information about choices, you can talk also about short-term or long-term plans if you need to do bridging therapies. Beware of conflict. So conflict can happen when there are gaps in the information or when people misunderstand what you say. We've all been there where we say something and they repeat back what you said, but they're mad and you realize they heard it exactly opposite. That's why repetition is helpful and verification that they heard what you said and not the opposite is important. There could be goal differences among family members. There could be tons of emotions, grief and guilt and anger. The family dynamic we've talked about. There can be legitimate mistrust of medical teams. And we aren't going to talk about that specifically here, but could be cultural, racial, or religious concerns that have created a lot of mistrust. And listen, it can be really helpful for you and help conflict not to escalate. So clenching their fists, gritting their teeth, the jaw muscles, a change in body language, the rooster position, which is chest out, more seen in men and arms back, pacing or fidgeting, a change in just the change in the tone of the room, or everybody's watching one person. If everybody in the room keeps glancing at one person, then you know who's the most likely to be the escalator. Any kind of disruptive behaviors. Really, when you see conflict escalation, there are ways to de-escalate. I've given a brief slide here. I think you guys have a pretty good sense of that, but this is partly for you just to have a little bit of a review, listening, respecting, being calm. Don't be defensive. Don't be rebutting. Better to listen than be preparing your answer back. Listen for what the real message is. A lot of times when people are yelling, what they're yelling about is not at all what the problem is. Ignore challenging questions, get back to the topic we want to talk about. Be really careful about what you insist on or drawing lines in the sand. It's okay to be silent. Let the room kind of be silent and let the silence calm and challenge the person who's being inappropriate. And don't be afraid to take a break and disengage. Sometimes we have to really protect ourselves. I kid you not, pandemic experience, fifth death of the day, only about 2 p.m. I've really had it. And when conflict starts to escalate, I would have to say, you know what? I can tell we need a few minutes to think about this. I'd like to come back in 2 hours and we'll talk a little more. And you can write down your questions and we'll talk a little more because I need to take a time out for myself. Once you've had the conversation, you've presented the information, it's okay to give bottom line statements. It's no longer medically clear which option is going to help. I have concern for suffering. Despite everything we're doing, they continue to get worse. We do not expect this to improve. Time is likely very short. All very helpful bottom line statements. And then allow silence. And this means you to let the family think and respond. So now I'm going to give 10 seconds of silence here. I'm not going to say a thing. This is on purpose, but I want you to feel 10 seconds of silence. So that's 10 seconds. And frankly, most of us can't tolerate a silence that long without piping in. My break-in time is about 4 seconds. I'm such a chatter. So I really have to count it. And so for you all, measure that time and feel it when you're not in a tense situation so that you can count it out in a meaningful way and have it be helpful. How to get yourself out, whether it's from escalation of conflict or whether the meeting is done. When you've completed your conversation, or if it's completed for now, if there's continued escalation and or there's been any kind of aggression or violence, and verbal violence is included. So don't discount verbal violence. Some of us have, by history or background, a lot of experience with verbal violence, and so we aren't as sensitive to it as others, but recognize it and don't tolerate it. And again, to limit your own exposure to a difficult situation. Plan your exit time and route. Sometimes you need to come in and say, I'm hoping this will take us about a half hour. Or you can literally say, we've been together 45 minutes. I want to spend as much time with you as you need, but I also have a couple of patients who need me to spend a little bit of time with them. I'd like to continue this conversation in an hour and a half at 4 o'clock, and I'll be back. And people appreciate if you let them know, I'm going to give you the time you need, but if your family member was having a crisis, you'd want me to answer the phone. Why is the doctor not calling back? And so that connects. You can signal the meeting's end, okay, I think we're all set here for now. You can quietly and stand up and move to the exit very gently. Move slowly, gently, don't be in a rush. So there are some special situations. What about when the family says, oh, don't tell the patient? So we all have some ethical concerns about that and patient right concerns. And so some helpful conversations can be, help me understand why you don't want me to tell them. Because we all know the patients usually know way more than the family thinks they do. What are you concerned, I would say? Have you had some previous experiences that make you concerned about this? Check to see if there's a personal, cultural, or religious context. In some cultures, the aging matriarch of the family doesn't ever get to know formally what's going on. They're not the decision maker in the culture, and that information is held usually by the patriarchal male. Just be aware of that situation, check about it, and kind of gently work through what that situation is. What about if they say, oh, they're a fighter? So my response is most people are fighting to live as long as they possibly can with the best quality of life they can. We've been fighting this disease as our strategy, but that's no longer working. And so I recommend a strategy directed towards keeping them comfortable and having the best quality of life. And we will fight just as hard or even harder for that. So if that's okay, you can diffuse that they're a fighter and somehow we're going to stop fighting. That's not the case. Sometimes a decision is pretty time sensitive. And so it's all right to introduce it by saying, there are some things that would be good for you to talk about together. There are some things we are worried about as a medical team. I want you to know what we're worried about. I have a sudden event that I knew might happen, but I didn't talk to you about that. And I tell you that's based on a personal bias in which I knew someone was crashing. We didn't talk to the family about it. They crashed. The wife looked me right in the eye the next morning and said, did you know this might happen? And I have never been the same because I did. And they have the right to know that. And it is something that we can gently say, I'm a little concerned about something, so I need you to know this may not go as well as we hope. I'm a little worried about this. Because when it's your worry, you're sharing the holding of that with them. If they need to make a decision, be sure you dial or video in people who can't be present physically, and do spell medical terms for the medical family, and repeat yourself. Once I was wine tasting north of Traverse City and had just sat down at one of the lovely places up there, and I'm in shorts and a tank top, and my sister says, I'm in the ER with mom, sweet 91-year-old Gladdy, and she says, they're putting him on some medication. She starts to spell it, LEVOPHED. And so I said, I'm on my way. And so, but the provider was, letting her know and be aware of that. And sometimes know also that there is a dial-a-nurse or a dial-a-doc for the family, might be friend or family member. And it's okay if they're okay with it, the patient's okay with it, consents are okay to include them. It'll help in a long time. Otherwise, you have a case of telephone for what you told them. Sometimes substituted judgment, where we really give a recommendation strongly, is really helpful. Be sure you're bringing the patient's voice into the process, that this is not just your recommendation, but this is based on the patient's voice and based around the patient's goals, not around treatment, but the patient's goals. An example, you can hear John Mulder's voice here. Given what you have told me about the patient and what we know about their medical condition, I would recommend, and talk about those true benefits and burdens of those interventions. What about when the feeding tube is the question? It's just not going to make things better. You can tell them the truth. Percutaneous feeding tubes are not recommended in certain situations, such as when adults have advanced dementia. We can offer careful hand feeding, and we can have known risk of aspiration. Tube feeding can be associated with a lot of complications, including diarrhea and agitation and increased use of restraints and worsening pressure ulcers from diarrhea. And so you can help them understand that just putting formula in does not guarantee absorption or benefit. And when you talk to people about that, they start to get it. I mean, our bodies are quite amazing in that near end of life, teeth are gone, ability to chew is gone, ability to intake is gone, appetite is gone, but we get into ketotic metabolism And we have this euphoric benefit from ketotic metabolism, so people don't feel hungry and better. And people don't understand that until you start to tell them about people who skip their renal dialysis because they know about that, and people who don't watch their diabetic diet, and pregnant women who are having eclampsia and decide to clean the house. So people know that ketotic metabolism, they've seen it, they just have to make the link here. So there are things you can do that can help them in this situation. Be able to talk cogently about pleasure feeding, that eating is important to the patient, given the situation, whether it's age or frailty or decline. We accept the risk of aspiration to allow the patient to continue to participate in their day-to-day activities, including eating, because they're so meaningful to them. This would be what they would want. What about when hope for a miracle is expressed? So I'm a practicing Christian, I'm religious, and I'm fairly comfortable with that. Not everybody is. I'm also pretty comfortable with that. I hope for, and I hope for my patients, that if they find religion to be an important part of their life and are comforting, and they're making religious statements, that we have some recognition of that. So this is not part of this conversation, but if that's uncomfortable for you, I am not recommending that you study comparative religions, because that's probably not going to be helpful for you. But I am recommending that you take a minute or two quietly when you have a moment to say, how do I feel about people who rely on religion in ways that aren't meaningful for me? And how can I talk to them respectfully about that in ways that don't deny who I am? And so it's something that needs self-reflection for you, bigger than for this meeting today, but something I don't mind talking with people about. And I am not someone who needs to have everybody identify with the faith that I have. Many religions will result in people hoping for a miracle, a scientifically unexplainable event. And no matter your background, it is okay to say, we hope for unanticipated recovery as well. But that truly a miracle or scientifically unexplainable event is probably what it would take at this point. And so I want to be ready for everything. If things don't go as well as we hope, I want you to be ready. If we get that miracle, that scientifically unexplainable event, I get to celebrate with you. But whatever happens, I want us to be ready. And some people will find it to be a faith failure to stop hoping for a miracle. Although there's no religion that says stopping hoping for a miracle is a faith failure, many were taught that at a very young age of many religions and faiths, and truly a spiritual advisor, appropriate, a pastor, or a priest, or a spiritual advisor to the person's faith or the family's faith can be helpful. And my experience, at least in the Michigan community, I've worked quite a bit around in Michigan, is that most spiritual advisors are willing to certainly talk with you on the phone if you have questions. And many are willing, if your own chaplain service is not resource enough for the situation, will either call in or even make visits to help you with a situation. So don't miss an opportunity to involve a resource that's meaningful for the patient and family to help you through a situation that can be challenging. So what about vet withdrawal? So patient's goals, again, I am not a fan of compassionate withdrawal or stopping aggressive care. I'm about, there's a burden to this treatment. It's not changing the situation. It's prolonging death. It has a lot of suffering. Talk about what life support could really mean and really talk about the picture. Code status. Have you ever talked together about how the patient feels about life support questions? Talk about full code. It's really about breathing, intubation, mechanical ventilation, CPR, and defibrillation. Those are the big four. And if people's eyes aren't glazed, you can talk about pressors and BiPAP and ICU transfer. Be honest about the prognosis of these interventions. If you don't know what the prognosis of these interventions are for your patient, you need to learn that now. And I'm not going to take the time to do it. It's a very interesting process. But truly, for any ICU patient, the likelihood of recovery, except for a few exceptional cases, from a CPR, a code event, that they ever leave the hospital is something under 2%. Under 10 that they'll survive it, under 2% that they'll ever leave a facility. So those are the kinds of things that are important when you're talking about what would the patient want. Partial code can be highly symbolic to some patients despite its clinical futility. And I have a soft approach, which is I like to honor the patient's wishes, not do things they wouldn't want. I don't draw a line in the sand about if we do this, we do that. I tell them it's really kind of clinically futile, but I will put down your wish for this. And it's highly frustrating to the response team, I know, but actually it is the appropriate decision situation. Be sure you can talk about therapeutic trial. If you want to proceed with a full code situation, we can do that, but people think, okay, do one thump or do one shock. Oh, no, no, no. If we commit to this, we're talking about a week of ICU care minimum. But if you want to proceed with this, we could reevaluate that in a week. But often people don't realize because they see TV, it's two defibrillations in the ER on a television show and they pop up and say, thank you, doctor. It's not realistic. And so you may have to address that. And it's okay to start the conversation about telling people, we would not be surprised if there was a sudden decline in the patient code. I don't want you to be surprised either. I'm hoping this doesn't happen, but if it should, I want to understand what the patient wants. And it's also to say, would the patient want that or would they want to permit a natural passing? Because we don't really talk so much about a natural passing. We talk about do not resuscitate. And I think, this is not going to be a huge thing for me because I'm retired, but I think in the next decade, this terminology and language about do not resuscitate versus allow a natural death is something to really seriously be considered because there's no question that do not do something is experienced way differently than to permit a natural passing and make that be a beautiful thing. So close up the meeting. Have you done your goals? What are you hoping for? What do you need? What do you want to do when what time is left? Restate your understanding of that. What are you saying? Recommend a plan. It could be hospitalization, ICU transfer. It could be hospice. It could be code status. It could be use of treatments. It could be whether there's a second opinion, experimental therapy, anything the family brings up that could be kind of Google surprises and what the best disposition is to meet those goals. Close up the meeting, restate what you understand it's going to be, repeat, repeat, repeat. See if they have any questions. Let them know that no matter what they decide, even if they know they're going to decide something they know is really not what you were hoping for, tell them we are here to support this self-determination despite our concerns. Thank everybody and gently leave the room. Some of our pitfalls, too much information, oversimplifying, big words, escalation of emotions from us, unrealistic expectations from whoever, cultural language or religious differences, implicit bias, tons of pitfalls to just be aware of. Some meetings are going to go lousy and it wasn't about you. Some patients and families got stuff going on that we didn't figure out. And if you misstep, amazingly, kind of like with parenting, you will get another chance. Be sure you document well who was there, essentially what you said succinctly and what's coming next. And take the time to debrief with yourselves, with your team, what we did well, what you wish had been different. Any emotional reactions in yourself. I'm an internalizer, so that's a little tricky one for me. You do the best you can with what's thrown at you, and then you try again. My favorite medical advisor, Mario Andretti. There are a couple of key references at the end. Questions. Can we take questions? And I'm going to pull this off the slide show for now.
I think you want to stop sharing.
And let me go to stop sharing. Questions. Yes.
I really like to talk about cultural differences.
Uh-huh.
And I do realize that cultural humility is like a big part of these conversations. In certain cultures, I've often found that there's almost more of a paternalistic attitude for healthcare providers, where they're sort of gonna expect you to actually be guiding them a little bit more, and you'll repeatedly be asked to actually make the decision for them. I'm just wondering, in your experience, how do you deal with that when it's sort of falling more to you? And then it can become challenging because your own values may differ from patients.
So the question is diving into cultural differences and cultural humility, understanding that some cultures may have a more paternalistic attitude about decision making and about healthcare team taking that role, and how we address that, particularly if we don't have the same values that the family seems to have, when we have a difference in the perspective about it. So I have a couple of thoughts. So you can imagine that a paternalistic situation isn't my favorite thing. Look at my age and my lifetime and the crest of the wave of my professional life. And so the first response I have is be aware of your own internal biases around that. Because that can be huge and can stimulate emotional internal reactions that aren't helpful. And so thinking about talking about it is really helpful. Second, we have a bias that substituted decision-making is always wrong. And that is not the case. And I believe our patients need to understand their choices, but I think where that breaks down is in making clear the burdens and the benefits of those choices. And I think we deal, and I don't mean to bash a specialty, but I think that there are implications. For example, in an oncology consultation situation, for example, I think patients hear there is a treatment and they don't hear, but these are the potential side effects because they really hope, well, 1/3 of people don't have these side effects. That'll be me, or I can tolerate those side effects because I'll be living, and then are shocked to find that their treatment side effects are killing them, not their disease. So that not listening clearly, that is a huge thing. So now, can we give substituted judgment in this situation? My deepest value is that we know what the patient would want. Do we have a clear understanding of the patient's wants and desires? And regularly in our practice, we will have situations where the patient wants something that I really don't agree with. And so I have to decide, have I given them good information and they're making an informed decision, or have I missed clarity of information? If they have good information, it's just that we disagree, that actually is their right. And it's okay to say, although I think in the situation, there are some concerns here, it is clear that the patient's wishes seem to be this. And so then you're allowed to put, for example, timed therapeutic trial event. So I think I will support proceeding with this, but I'm going to recommend that we reevaluate this in 48 hours or a week or whatever time is appropriate for the intervention. So that if there's increased suffering, we can come back around and talk about that suffering I'm concerned about. It's okay to not insert yourself in, but responsibly give that information. Did I cover your question? Did I get all the corners?
Well, I think we've swung, we went from paternalistic,
Uh-huh.
50 years ago to now it's all the patient. And I feel like actually that's at times heavier on the patient and the family because they are not educated to the degree of understanding the nuance of the disease. And then they're just given these options, like you're at a car lot and they have to choose one. And if you can gently guide them to the one that you think makes sense, either for their clinical scenario or again, the patient's desires.
Fire engine red.
Yes, exactly. Warmer. Would your family member prefer a bit warmer? I think the relief that those families feel without forcing them in. I mean, the old paternalistic view was pretty much you don't get an opinion. This is what we're doing. See you later. I mean, we don't need to go back to that. But this idea that now that it's hands off and it's really up to the family. I'm like, it is up to the family. They get to be the final say. But if they are not actually informed decision makers or have actual informed consent, nor do they have someone who can guide them, like an advocate, that is sort of like our job. I just have seen many times where they feel so much relief that someone said, honestly, like if this was my family member, this is what I would do. I mean, obviously it helps if you agree with the goals, but just in general, if they can hear that this is the right thing to do as opposed to like there's 4 options. I don't know. It's just.
So I agree with this commentary that culturally in healthcare, we have swung from a very paternalistic telling you what to do. And I've experienced that where, there were tests done and serendipitous findings, which they aren't disclosed to you, things like that. And then come back later, like that's been there for since the last exam. I'm like, what are you talking about? So that still can occur, but swung in some ways to just giving the options without giving the true burdens around your decision. And the benefits of each are often given, but not the burdens. And helping people kind of understand what that kind of means. I'm kind of on a rampage about prostate cancer monitoring in males
Yes.
of all ages. And I'm on a rampage about that in part because of personal experience, of course, but because experiencing it personally, the options were presented. Where I got the best information was from oncology PAs, and I said, so what do you recommend? And they 100% to a person said, get it out. Not any of the other options, get it out. But I'm keeping being told they aren't going to die from the prostate cancer. Oh no. But then I realized in my palliative care practice, they're the people whose bone pain is the most difficult to manage. They're not going to die from their prostate cancer. They're dying from their immunotherapy and the side effects and their blood loss and incredible bone pain. And so that is kind of the illustration. We really have, we in that situation, but generally speaking, need to understand a responsibility about people understanding the burdens of the choice, short term and long term. And I do think people are uncomfortable with a difficult conversation or don't even really know for sure and don't give that information. So good
And
question.
Gretchen has her hand raised. Go ahead, Gretchen.
Okay, can you guys hear me?
Yes.
Great, okay. I thought great discussion on this, and thank you, Barb, for this excellent lecture. I'm going back to Amy, what you were talking about with the paternalistic or not. I just wanted to share sort of what helped me think about this. As people have said, it's really helpful when people are given some guidance. There's some people who are clearly overwhelmed with making decisions, and you can tell, sometimes after one or two conversations, sort of how much they're really leaning on us to, share maybe our opinion. And I think it's okay to do that, but we're not doing that. I try to avoid the things, if this were me or my family, because some people will ask you, what if it was you? I even if they ask it that way, I don't say, well, this is what I would do. Because what I end up doing is I always go back to what have they shared. It's all about their story. It's all about what you have taken that time to map out their goals. You've asked them questions along that. Maybe it's been several times that you've met with them. We talked with our PEDS team, they build relationship over years. So you're pulling all these things that this data that you listen to and collect, and that's our expertise. And say, based on your desire to be at your daughter's wedding in a couple of months, or you want to go on this trip or you want to do this, I would recommend this. And you sort of pull what's important to them. And then you can make a recommendation. How does this sound for you? Does this seem to align with what you think? And we're weighing those risks and you're weighing the benefits. And this is after they've heard all of that and they understand the information, which is the first part. But if you do that, it is not paternalistic. You are helping guide them. And some people want more of that than others. But I think that's actually part of our job to do it that way. But I feel much better with that approach than thinking I'm just going to tell them what I think they should do in this situation.
Absolutely. Patient is the center of the decision. Absolutely. Thank you.
And that comes down for the term, and when we're studying, that comes down to that term shared decision making, where everybody's coming to the table. Patient family is coming to the table with their goals, ideals, and desires. You as the provider are coming to the table with your expertise, and you're trying to align those goals together and figure out what's going to be the best fit.